Hi everyone, my name is Dr. Trish Harkins from Dublin, Ireland, reporting for Room Now from ACR 2022. Today, I am so delighted to be joined by Professor Laura Coates, who, as many of you know, is a clinician scientist at the Nuffield Department of Orthopaedics, Rheumatology and Musculoskeletal Science at the University of Oxford. So today, Professor Coates has very kindly agreed to discuss her ACR highlights in psoriatic arthritis with us. So before we begin, thank you so much, Professor Coates, for taking the time out of your exceptionally busy schedule to have a chat with us today. I really appreciate it.
Thank you for having me.
Brilliant. So to begin, I really enjoyed your presentation on the personalization of psoriatic arthritis therapy that you presented as part of the Spondyloarthritis Community Hub on the Sunday of ACR. So following on from this, I was just hoping you might briefly talk us through where you see the personalization of psoriatic arthritis therapy currently is, and maybe just to give us a brief outline of your ongoing optimized clinical trial as well.
Yeah, so I think personalizing treatment has been talked about a lot in rheumatology, and we've never really got there. But I think as we get more and more therapies, it seems more and more important. When we just had TNF inhibitors, we had a very simple route to follow. We tried DMARDs. If they didn't work, we escalated up to TNF. And if one of them didn't work, we cycled to a different one because we didn't have any other options. Whereas now we have so many different drugs. And I think in such a heterogeneous condition like psoriatic arthritis, we're trying to get better, at least clinically, at picking out which patient suits which drug. And really, we've had limited data from head-to-head studies to date. We've had a few now, but not very many. And all of them have really showed that the arthritis outcomes kind of look the same or pretty equivalent. So actually, the differences tend to be beyond the peripheral arthritis. You've got drugs that are better for skin psoriasis in head-to-head studies compared to others. You've got things like efficacy in IBD or uveitis that might help you pick a particular drug, as well as the efficacy in axial disease. So I think we already are in clinic doing some form of personalised medicine and trying to pick the right drug for the right person. But I'm very aware in clinic that I don't know the right answer for most of the patients in front of me. There are sometimes drugs that obviously aren't the right answer.
Yeah.
But it can be really tricky to say, actually, any of these three drugs might work just as well for you. I don't really know. And hopefully, with some more laboratory research and a bit more science behind us, we could get to the point where we can pick out predictors of response. And that's always tricky because when we look in clinical data sets, we can pull out predictors of response, but they tend to be always the same thing. And they're predictors of a good response in general, not to drug A or drug B, but just that you have easier to treat disease. That doesn't really help. What we want to know is what are the specific predictors for one drug rather than another drug. And that could potentially allow us to select the right drug for the right patient before we're having to trial drugs for sort of 12, 16, 24 weeks, potentially for them not to work, and then for a patient having to switch again.
Yeah, no, and absolutely. And even for patients, and as you were saying, like even economically, it would just be brilliant to get something for that. And I suppose that leads me on then to your trial. So the optimized trial, obviously we know what's behind driving it, but can you give us a brief outline of what you're doing?
Yeah, so this was building on a study that was done a few years ago in Japan. And they looked at precision medicine for PsA. So they took a small group of patients and they split them into two groups. One group had standard care, so they got given whatever they would normally be treated with. And for the most part, that was TNF inhibitors. And then they had a second group, less than 30 patients, who had peripheral blood taken and then were sorted into different drugs based on their Th17 and Th1 phenotype. So they picked different drugs depending on whether people were high in levels of activated Th1 cells or high in levels of activated Th17 cells. But it was a really, really small study. It looked at lots of different outcomes and found some differences, but with no pre-specified primary outcome. So it was a little bit difficult to draw firm conclusions. So what we wanted to do is build on that. So the Optimise trial is currently running at a number of hospitals in the UK, in England and Scotland. And what we're doing is recruiting patients who are about to start their first biologic for PsA on standard NHS rules. We're taking a lot of peripheral blood at baseline for all sorts of tests. We're stratifying them according to their Th17 levels, so the same marker measure that was used in the Japanese study. And then we're randomizing them either to TNF or to secukinumab in equal amounts. So we're not actually testing a precision medicine approach in this trial. The patients don't get a drug selected for them. They're equally being randomized to the two different drugs. But at the end, that will allow us to look at a number of baseline markers and whether they interact with the outcome depending on the drug. So whether we can pick up predictors for response to TNF and or predictors of response to IL-17.
That'll be amazing. Yeah.
And obviously we're looking at the Th17 because of the Japanese study, but we're pretty convinced that it's probably not the only test that's likely to be useful in quite a complicated disease. So we're doing a lot of intracellular cytokine measurement, and we're doing RNA sequencing to look for different markers that we could identify in the future. Brilliant. And hopefully a panel of markers. It's probably not still going to be one test, but maybe a panel of different things that we can use to say whether you're more likely to respond to one drug or the other.
And I think the benefit is the panel will be on blood or will be on serum. So it is something easily transferable into a rheumatology clinic. So that's fantastic. I can't wait for the results of that. Moving on a little bit, was there any other abstract throughout ACR22 that kind of caught your eye or that grabbed your attention or that you were particularly impressed by?
So quite a few. So we didn't really have new drugs in PsA at this meeting. There were no big RCTs. So a little bit of additional information and extension data with different drugs, but nothing sort of brand new. So it was more the other stuff, the investigator-initiated stuff that kind of was an obvious highlight. So I think there was a really nice study by Leahy Edda in Canada. They looked at cardiovascular risk in PsA. And obviously we know it's a big issue for our patients. We see a lot of metabolic syndrome and cardiovascular issues. And we've talked about before whether our patients should be considered to be at higher risk just from having PsA. And they looked in their data set. They had about 6% of their patients who developed new cardiovascular events. And they looked at different models to try and predict that. And really interestingly, the model, the kind of standard model with blood pressure and diabetes and cholesterol and all the usual things, predicted cardiovascular events just as well as a model that also had measures of psoriatic disease. So adding in joint counts or PASIs or complicated things actually didn't really add anything. And I think that's really useful for us to know. And it's a really good message to share with rheumatologists and with GPs that actually it's just the simple stuff. You don't have to do anything different or complicated. Yes, these patients have more metabolic issues, but if you manage them well, then you can reduce their risk. It's just the sensible things like controlling blood pressure and cholesterol and that kind of thing.
Yeah, and I think we're far more likely, if it seems something simple and not terribly out of the ordinary, we're far more likely to do it. I know, Prof. Eder had other great studies as well with the PsA study and dietary. So it's nice we're kind of looking at patients more holistically, I think, post ACR 2022. And I suppose following on from that, is there anything at all, Professor Coates, you're going to change in your practice following on from what you might have seen at ACR 2022?
I don't think anything so specific in terms of new drugs. There was some nice data from the UK early arthritis cohort showing that we're probably under-treating our PsA patients. That's something I want to look at in our early arthritis clinic because I lead that service. The PsA patients were much less likely to get DMARD therapy compared to rheumatoid patients, and then had poorer outcomes related to that. So I think that's something that we want to be aware of and looking into. And I'll be sharing the standard cardiovascular risk data. So I think that'll be useful and hopefully reassuring to GPs that actually they can just treat them as normal.
Yeah.
There's not anything additional and complicated they need to remember. But hopefully we can, remind patients and primary care physicians in terms of managing those things well.
Yeah, no, I absolutely agree. I definitely think that was one of the main things I got out of this ACR as well. It's kind of viewing the patient a lot more holistically, looking at all the other things that we can easily modify and educate our patients on as well. So thank you so much, Professor Coates. I've really enjoyed our conversation today. And again, thank you for taking the time out to have a chat with us. Thank you to everyone who listened. Please do subscribe to Room Now and follow us all on Twitter. Thank you.